Juvenile angiofibroma. So we're talking about tumours of the nasopharynx. The nasopharynx being the uppermost part of the pharynx, the first part of the pharynx, which actually is continuous with the nasal cavity and extends from the base of the skull to just above the soft palate. So when it comes to juvenile angiofibroma, it's in the name. Juvenile is young person or members of the youth, or a young person. An adolescent is a juvenile. Angiofibroma, anything ending in oma is a benign tumour. Carcinoma, malignant tumour. Here we've got an oma. We've got an angiofibroma. Angio means blood vessels. So this is essentially benign angiofibroma. It's a highly vascular tumour of the nasopharynx. It's a benign, highly vascular tumour of the nasopharynx, and the typical presentation of this occurs in young males around the age of 12. It's a young male. The origin is, the cause of it is not that well known. However, it's really from, what we do know is it's from a hematomatous. Like, you know, a hematoma. A hematoma is any kind of tissue element which allows for the growth of a tumour. It's any kind of tissue elements coming together which can then allow for disorganized tissue growth, otherwise known as a tumour. This tends to affect young males. These young males are going to have these hematomatous nidus present there. They already have this kind of like abnormal tissue present in their nasopharynx. And it's kind of like this hematomatous nidus gets activated by testosterone. So in simple terms, what happens in juvenile angiofibroma is that these patients, these are young males, and they already have this abnormal collection of tissue. As soon as puberty hits and testosterone increases, that testosterone is then enough to trigger that hematomatous nidus, or that testosterone is enough to trigger this nasopharyngeal tumor to start growing. And when a tumor starts to grow in the nasopharynx, as you can imagine, it will cause obstruction to breathing. It will cause obstruction to the nasal cavity. So you can expect unilateral nasal obstruction. The other thing you can expect in these patients is recurrent epistaxis, and that is because this is angiofibroma. It's a highly vascular tumor, and the fact that it's so highly vascular is what makes it so prone to bleeding. And like, these patients always present with recurrent severe epistaxis. These patients have severe bleeding from the nose, and they may even have pallor and anemia. Now, before I go into the other clinical features, I want to talk about the course of the tumor itself. The tumor starts in the posterior wall of the nasopharynx, or where the choana are found, which we discussed in another video. So it starts from the posterior wall, and now it can extend, and it can start to go up to basically, you know, the maxillary sinuses are around the nose, and if you just imagine there's an area under the zygomatic bone, kind of like towards the backside. It's called the pterygomaxillary fissure. So just maxillary, behind the maxillary bone, pterygoid part of the sphenoid bone. So there's a pterygomaxillary fissure. From there, because firstly, this tumor can invade into the adjacent maxillary sinuses, because it's in the nasopharynx. Maxillary sinus are not far from there. Once it invades the maxillary sinus, it can even go through the maxillary fissure up to the pterygopalatine fossa, from where it can enter the cranial cavity through a sphenopalatine foramen. And I will give you a diagram at the end of this video where you can look at this pathway. It's very simple. There's a little fissure between the maxillary bone and the sphenoid bone called the pterygomaxillary fissure. Through here you can enter the pterygopalatine fossa. Through there you can enter the sphenopalatine foramen. Through there, this tumor can invade the brain. It's actually, it can rapidly extend into surrounding regions, and it can even extend into the in the orbits and the intracranial cavity. Now, if the tumor extends into the orbits, that's going to cause something else. If it extends into the orbits, it's obviously going to cause, through the inferior orbital fissure, it's going to cause proptosis of the eyes, and it's going to cause these eyes to bulge out, exophthalmos. The other stuff that you need to know is that the angiofibroma itself has only an endothelial layer. So that means it's not this thick, robust structure. It only has this endothelial layer, and its blood supply is very, very thin, meaning that this tumor is very susceptible to bleeding. It's always going to be bleeding, and like I said, these patients will always be presenting with nosebleeds, recurrent epistaxis. Now, in the nasopharynx, there's also something called the opening of the eustachian tube. When there's an opening of the eustachian tube, any kind of obstruction of the nasopharynx itself by this nasopharyngeal tumor or by this angiofibroma, a juvenile angiofibroma, that can cause an obstruction to the eustachian tube itself. Eustachian tube is supposed to be an air-filled is supposed to lead to the middle ear. The middle ear is supposed to be an air-filled cavity. Now, what will happen if this is blocked? Can fluid build up in the middle ear? Yes, it can. If the eustachian tube is blocked, can fluid build up in the middle ear? Yes, it can. Can some kind of infection start to appear in the middle ear? Yes, it can. And that's known as otitis media. And by the way, when there's an obstruction of the eustachian tube due to this kind of tumor, this will result in what we call conductive hearing loss. So this will cause conductive hearing loss, and it can also cause secretory otitis media, as I already mentioned. So we talked about how if it's a tumor, it's a space occupying tumor. It can cause a nasal obstruction. It can cause conductive hearing loss. We talked about how it can go into the cranium and intracranial spread. The other stuff, we talked about the exophthalmos as a result of it going into the orbits. Now, what is the prognosis? The prognosis is either spontaneous regression at sexual maturity of these patients, or it starts to extend to the surrounding structures, which is very, very dangerous. It can be very dangerous when it progresses and extends. These patients are going to have the clinical picture of generalized pallor or anemia due to excessive epistaxis. They can have stunted growth. They can have face signs such as proptosis in the eyes when the tumor reaches the orbit, facial swelling due to maxillary sinus or any other kind of infiltration. Oral signs include eustachian tube obstruction, conductive hearing loss, and the nasal implications can be unilateral nasal obstruction. You're not going to now. There's something really important to understand, that in the investigations you will not do a biopsy, because doing a biopsy may lead to literally relentless, uncontrollable bleeding, which can cause the patient to die. So do not do a biopsy for these patients. You will kill them. You need to do a, number one, gold standard is a CT scan. Number two is an MRI, and number three is a carotid angiography. By the way, which other tumor or which other condition do we not do a biopsy in? A lingual thyroid. We don't do a biopsy in a lingual thyroid. Off point, the thyroid embryologically is at the base of the tongue. It's supposed to migrate to the normal place where the thyroid is. If it does not migrate and there's still some kind of appearing mass, ectopic mass near the tongue, which is this ectopic thyroid, that's called a lingual thyroid. Now, we don't remove it completely, because it's probably going to cause hypothyroidism in your patient, because there's likely no other thyroid tissue present in that patient anyway. And secondly, you do not take a biopsy of a lingual thyroid, because it's highly, highly vascular, such a blood supply, it will cause excessive bleeding. So again, in the two conditions in which we do not take a biopsy is a nasopharyngeal tumor or a juvenile angiofibroma, nasopharyngeal angiofibroma, or a lingual thyroid. Now let's continue. What is the treatment then? It's a surgical excision with preoperative embolization. Embolization is when you block the blood supply to the tumor itself, and you want to do a surgical excision. Radiotherapy is an option, however, it's not taken in young patients because you want to avoid the risk for secondary cancer, basically. Okay, you can also give hormonal treatment. Now I want to end with firstly the diagram. So this diagram shows that there are different connections to the sphenopalatine foramen. They're numbered 1, 2, 3. So there's a connection between the nasal cavity and the infratemporal fossa, which can then cause the tumor to spread intracranial. So number 1 here is the pterygomaxillary fissure, from which it can go into the pterygopalatine fossa, from where it can go into the sphenopalatine foramen. So that is it. And there's in red is the gap between the maxilla and the sphenoid bone, which is known as the pterygomaxillary fissure. Now, just to end off, here's a mnemonic picture. So this is a kid, a young adolescent male who has proptosis of his eyes because of the tumor having spread to the orbits. His nose is blocked because he's got nasal obstruction because of this nasopharyngeal angiofibroma, benign tumor, highly vascular. He's also got a piece of ham in his mouth that he needs, hamartoma nidus. See what I did there? He's also got facial swelling, and he's also got one ear much smaller than the other. He's got conductive hearing loss due to eustachian tube obstruction, and there's a lot of blood coming out of his nose, which is supposed to represent recurrent epistaxis. And he's about to go on the slide, the sphenopalatine slide. The sphenopalatine is the sphenopalatine foramen, and the slide comes back on its own because this tumor can spontaneously regress when the child reaches sexual maturity. Okay, thank you. These notes are not my own. I found them online if anybody wants to claim them. Thank you for listening, and please like this video and subscribe. Thank you.